Okay, thank you, Professor Basuni. We will just, if we have any further time in the end of our today's meeting, we could go for the last questions. I'm going to shift now to Dr. Tamer Roushdy. He will start to present to us revisiting on Dean's crisis. Dr. Tamer from Ain Shams University. He is an assistant professor and he will now start. Please, Dr. Tamer.
Thank you, Dr. Hussein. Yeah, I know that we are at the end of this webinar, so my presentation will be as fast as possible. We are approaching 10 p.m. at our colleagues at United Arab Emirates. And so why my presentation is on Undyne curse revisited. I have nothing to disclose. Targets behind the current presentation will be historical and mythical background behind the term Undyne curse, the case presentation, neurological basis of automatic breathing, and conclusion, how we saved the hands, which is the nickname of our patient. Mythical background behind the term Undyne curse. Actually, Undyne curse is novel name. The true name of such disorder is central hypoventilation syndrome. The name Undyne curse is based upon a mythical mermaid named Undyne. The daughter of Poseidon, god of the sea. Mermaids were known for their immortality, which they lost if they married a mortal. One day Undyne fell in love with a knight, Hans, who she married, thus losing her immortality. Yet by time Undyne left for another woman, and he was cursed to live on conscious basis. He will not breathe if he fell asleep, and that's why it was termed Undyne curse. Our case is a 57-year-old male, diabetic, hypertensive, with recurrent cerebrovascular stroke, dating 2013 and 2016, with MRS of 1. He presented to our ER by sudden onset, 11-hour duration of swaying of weight to the left, vertigo, nausea, and vomiting, followed by dysphagia to fluid with nasal regurgitation, hoarseness of voice, and partial ptosis of left eye with an NIH of 5. MRI brain with diffusion weighted imaging showed restricted diffusion along the left lateral medullary zone, as shown in the figure. A few hours after admission, the patient suffered from tachypnea with drop of oxygen saturation to 60%, which was followed by bradycardia, 17 beats per minute, and gasping. Patient was rushed to ICU, intubated for assisted ventilation for 24 hours, after which he became stable and extubated once more. 12 hours later, while asleep, the patient developed cardiopulmonary arrest, was subjected to cardiopulmonary resuscitation, and assisted ventilation was performed. 2 days later, he was shifted to continuous pressure, airway pressure. However, he suffered from repeated attacks of apnea at night while asleep and was placed on bipositive pathway airway pressure. ECG and biochemical and metabolic labs were within accepted limits. Carotid duplex revealed the diffuse atherosclerosis. Echo showed grade 1 diastolic dysfunction, being hypertensive patient, and mild concentric ventricular hypertrophy. Glycated hemoglobin was 8.5, and lipid profile was normal. And a follow-up MRI was stationary, as well as chest X-ray that was free. The patient was ordered polysomnography prior to discharge and showed increased percentage in REM sleep. However, after 90 minutes from sleep initiation, the patient developed apnea that was central in character, with drop of oxygen to 49% and bradycardia, with average heartbeat of 39.3 beats per minute, all of which were corrected by re-administration of assisted ventilation. After consultation with a pulmonologist, a tracheostomy with valve to aid in speech and a pacemaker were placed to manage bradycardia attack, and the patient was charged on portable ventilator with BiPAP mode during sleep and was stable along 2 years follow-up. These are the tables that showing the respiratory event summary of a polysomnography. As is shown in the first table, the central apnea was taking the upper percentage of the types of apnea with a total of 27 times. Obstructive sleep apnea was also taking account in such patient with only 4 attacks of obstructive sleep apnea. Mixed form apnea was 21 of the total forms of apnea, as well as summary of the rest of the polysomnography were irrelevant. The oxygen saturation oximeter was ranging from late 70s to early 90s, and the respiratory event summary was showing the different form of apnea, which, as we said, central apnea was taking the lead in such patients. This is the figure showing the sum of all polysomnography findings. We can find that the central apnea in blue was taking the upper limit form, and the obstructive apnea was sharing by 4 attacks, just 4 attacks, and mixed form apnea was also sharing a good percentage of the type of breathing disturbance. And as we can see here, the oxygen saturation ranging from 80s to early 90s. What about neural correlates of involuntary breathing? Breathing within the central nervous system occurs through 2 centers. The voluntary breathing occurs through cortical control, while involuntary control is taking place or is centralized within the brainstem. As evident from the figure, centers of involuntary breathing are located in the medulla and in the pons. The medulla centers are the final centers within the brain that send signals to respiratory muscles to maintain breathing in situations like sleep. Any damage to such centers, which are termed central respiratory pattern generators, will affect breathing pattern, causing apnea. The medulla has actually 2 centers of respiratory pattern generators, which are the dorsal respiratory group, which initiates inhalation and control rate of respiration, and extending along most of the length of the dorsal medulla. And this dorsal group receives signals from the pontine respiratory group, receptors within the lung, and sends signals to ventral respiratory group to modify breathing rate. And the other center within the medulla is the ventral respiratory group, make up the exhalation or the expiratory component of the involuntary breathing. This area is in the ventrolateral part of the medulla and contains both inspiratory and expiratory neurons. As for the pons, the pontine respiratory group are interconnected and send signals to the dorsal respiratory group of the medulla and are responsible for respiratory rate and volume control. And so we can conclude that the medullary centers of respiration are the most important center for maintaining involuntary breathing, for example, at night or while we are sleeping. Posterior circulation strokes account for just 20% of all strokes, and the lateral medullary stroke account for 2 to 3% of such posterior circulation stroke. So they are rare forms of stroke. The lateral medullary syndrome is not much encountered on our daily practice, but when it occurs, it's usually present with dysphagia and dysphonia and rarely involves central respiratory pattern generation. But if such areas are affected, central apnea could be fatal if not kept in mind. And so the issue in such patient is that polysomnography, which is usually being asked or ordered on elective basis, was so important and crucial for such patient. It is an uncommon investigation in stroke cases, yet in lateral medullary syndrome, and in our case, it was a life-saving investigation. As I said, I will not increase in my presentation, and I will be so concise. To conclude, and Saving Hands, who is the name of the Mythical Night of the play that was dating 1965, discussing Undine Curse. Saving Hands was based on collecting the puzzle pieces of this stroke case that are The patient is suffering a lateral medullary infarction that was evident by the coronal cuts of the diffusion MRI. The patient suffered desaturation with hypoventilation up to brady arrest on going to sleep, and polysomnography confirming central sleep apnea was performed, and a final conclusion that a portable ventilator while asleep was ordered for such patient where he was kept alive and was supported by such ventilator for 2 years follow-up. What about after the 2 years? Usually, central sleep apnea secondary to lateral medullary syndrome is a self-limiting condition. It resembles, for example, the adductor palsy, for example, in case of infarctions or so on involving the insula. And so it is a self-limiting condition. By time the patient will overcome the disturbance he is suffering, and usually the tracheostomy and the aided ventilator will be not needed any more. And thank you, and stay safe.
Thank you, Tamer, for this interesting case. And actually, I think it's quite rare. I mean, across my career, this is because I witnessed also this case with Tamer. This is my second case to see of this on dying curse. And as Tamer said, if we didn't keep in mind that, especially in the lateral medullary region infarctions, probably we can easily miss such a cases, and probably we will find the patient dead while he is asleep. So it's very important to keep in mind that maybe we can do polysomnography for such patients. If you have any questions, you can just put it in the Q&A, and also I will try to, I guess there is some questions for the previous speakers. Also, maybe if we have some time, we can take 1 or 2 questions for the previous speakers. But there is a question for Tamer. When should you suspect the diagnosis in daily clinical practice, and when we have to indicate polysomnography?
Actually, as you, Professor Hani, stated, the lateral medullary syndrome and the undying curse is a very rare stroke to be presented. Actually, I was checking the reviews. It's presented as in the form of case reports, just case reports. So from my point of view, I will suspect central apnea in any patient who is suffering from a lateral infarction involving the lateral medullary aspect, even if he is not complaining of any form of apnea. And because it is a life-saving, I will ask for polysomnography for any patient who is actually suffering a lateral medullary syndrome, as evident by the diffusion restricted MRI.
Can we consider a diaphragm-based stimulator?
The only reported cases that were protected from the hazardous or the fatal effect of the central apnea were through the BiPAP, which is the bi-level positive airway pressure, which differ from the continuous positive airway pressure because it has 2 forms or 2 modalities within the ventilator, which is the inhalation and the exhalation technique. So this is the only written or a proposed life-saving condition for such undying curse condition.
And actually, I can recall these patients because he used to visit my clinic afterwards. I mean, it's not a very difficult situation because the patient used to sleep on the BiPAP, and then while he is awake, he's moving around with tracheostomy, and they fixed to him this tube through which he can speak, and he can, I mean, practice his daily life. Of course, Tamer, you remember this patient?
Yeah, yes, Professor, yes.
There is, I guess, a question to Dr. Bassiouni, but unfortunately he left. But probably also I can answer it because also I witnessed this Dr. Bassiouni, which is a hemodynamic stroke. Hemodynamic stroke is different from the thrombotic stroke or atherosclerotic stroke because The problem here is the poor perfusion to the ischemic region of the brain, either due to, for example, a drop in the blood pressure, or maybe because the vessels are in this region are mostly occluded. Sometimes the case the Dr. Basuni showed, they call it misery perfusion, because all the time this region is under misery perfusion and is ischemic. And as he shown, the time to peak when we did the diffusion perfusion study for this patient, his time to peak was 4 minutes, and some regions even more than 4 minutes. So all the time his hemisphere is at risk of developing or passing into infarctions. That's why it's very important to perfuse this hemisphere. So it's different from a sudden occlusion of a vessel due to a sepsis. I guess we can I can't see any more questions. So, no. Yes, there is a new question also for Dr. Tamer. Is there any oral medications for improving symptoms of central apnea? Can we give transcranial magnetic stimulation in this case, or bi-level PAP in central apnea with desaturation? Do we give supplementary oxygen?
As for transcranial magnetic stimulation, being a member of the neuromodulation lab at our university, Ain Shams University, it is targeted mostly for the cortical insults. As for the brainstem, I don't think that it is applicable to be performed, and such insult is actually along the medulla, so it is very not helpful. As for oxygen supply, the patient while awake, he is voluntarily controlling his breathing, so he is not in need of oxygen, although the saturation usually is a little bit in the early 90s, but while asleep, he is in need for a continuous pressure of airways that will aid his breathing or the muscles of respiration, so as to prevent the apnea rather than oxygen supplementation only.
Also, what about the prognosis? Actually, it's still this patient is coming to my clinic, and he's doing fine, and repeatedly he's doing. Actually, at a time we did Holter, we did even temporary pacemaker for him to monitor also his cardiac condition, because this patient passed into cardiac arrest, I guess, twice, right, Tamer?
Yes, he suffered cardiopulmonary arrest. One was just brady arrest,
Yes.
and the second one was a total arrest while being hospitalized.
Yes.
And on consulting the pulmonologist as well as the cardiologist, a pacemaker was ordered and was placed for controlling the rhythm of his heart, as well as the portable ventilator with the tracheostomy.
Yes, but still he's using the PIPAP at night, most as far as I remember, because I guess I didn't see him for a few months, but last time I saw him, he was still using the PIPAP. So there is also a question from in pediatrics. In neonates, we use caffeine as a respiratory stimulus. Is it useful in adults?
I actually can't answer this question. I am not acquainted by this role of caffeine.
But I think it's I mean, we are in a drastic situation, so I guess it will not be enough, definitely. I mean, this patient has...
Yes, it may be like the role of TMS. It's just a trial, but I think for the sake of protecting the patient from a fatal prognosis, I don't think that it will be so hopeful.
Another question, why PIPAP and not CPAP? I guess the...
CPAP,
yes,
yes, Dr. CPAP is actually directing it for obstructive sleep apnea. Such patient is not suffering an obstructive sleep apnea, and that was evident by the polysomnography and its analysis of the results. But BiPAP is positive or bi-level positive airway flow. So it is having two techniques, one that will aid in inhalation and one will aid in exhalation. And that's why it is more helpful in central sleep apnea rather than obstructive sleep apnea, where the CPAP is the preferred choice.
So I cannot see any more questions. So if this is a situation, I will conclude by thanking our dear speakers, Dr. Asma, Dr. Bassiouni, and Dr. Tamer, and remind you that our next wave will be on the 16th of March in Kingdom of, this will be arranged by our dear colleagues in Kingdom of Saudi Arabia. We are looking forward for this wave, and I think it will be very interesting one. So waiting for everybody to participate and attend, and have a good night, and sorry to keep you such a late night. Goodbye, everybody.